what I'm finding is like, like I was saying, like my friends text me a lot about their babies. And a lot of times, I want to say, what did your doctor say? Right?
Right.
Like do
Right.
what your doctor, because I'm not a physician. Yes, I know a lot about babies, but I think there are times where the bedside manner and those important conversations where it's like literally, okay, this is do if this then that, if this then that are so important to have with parents.
This is NICU Babies Parent Support with Kathryn Whitaker, a podcast from Hand to Hold, a national nonprofit that provides free personalized support, resources, and community before, during, and after a NICU stay. My conversations here focus on education and personal stories with medical and hospital professionals, counselors, therapists, and NICU moms and dads from across the country. So whether you're preparing for a NICU stay, you're currently there, or you're months and years past your stay, you belong here. The NICU is hard. We're here to help. I'm your host, Kathryn Whitaker, the mom of 6 children, including my very own NICU baby, and I'm so grateful that you're here. Well, howdy, everybody. Welcome back to the podcast. We have had a great season so far. Last week, you all got to hear from a mom. You got to hear from her heart. And my desire and my plan all along was for you to have a lot of hope this season. And I think Mary delivered last week. So today we're going to switch gears a little bit, and I'm visiting with a NICU nurse. I got to admit, I love visiting with NICU nurses. One, because we all know that they're superheroes. Yes, I think we can all agree with that. But I'm betting that you might be in the thick of taking care of a kid who has RSV right now, or you have been there, or you're worried that you're going to be there. So we're going to visit a little bit about RSV, what it is, what the symptoms are, how you can treat it, what you should be looking for, whether you're in the NICU or maybe you're post NICU and you're at home and you're having to navigate it by yourself. And I think there's just this unique perspective that a NICU nurse brings. One, they have amazing experience, but they also have profound compassion. And I know that you're going to love our conversation today. My guest today is Chelsea Sams. She's a NICU nurse and an educator with a passion for helping new parents navigate life with their newborns. After starting her career as a mother baby nurse, she transitioned to the NICU, yay, and expanded her expertise through travel nursing and becoming a child passenger safety technician. Chelsea holds a master's degree in nursing education and founded I Know Newborns in 2023 to support parents in caring for their babies. In her free time, she enjoys modeling, baking, and self-care. And with that, we have a great conversation ahead. So let's chat. Well, I'm always excited when I get a chance to visit with a NICU nurse. So Chelsea, thank you for being here.
Thank you for having me. I'm so excited to be here, Catherine.
No, I'm glad you're here. I have a million questions, but I'm going to start with the obvious one is why nursing? And then I mentioned in your bio, you started out as a mother baby nurse and then you
Mm.
switched over to the NICU. So it's a two-part question. Why nursing? And then why the switch over to the NICU?
Yes. Okay. So nursing. I um I always kind of had a knack for healthcare going all the way back to high school. So in high school, I was trying to decide whether I wanted to be a doctor or go into nursing. And so when I was doing my research and chatting with people within my community and my network that were doctors and that were nurses, something that always stuck out to me when I spoke to the nurses was that they all loved their job and they always led with that how much they
Oh, that's
loved being a
nice.
nurse. And so that stuck into my mind when I was looking at undergraduate programs. And I said, I want to go into nursing because I want to do something that I'm going to love. And
Right.
all the nurses that I've spoken to all love nursing. So that's kind of how I got into nursing. I did like shadowing experiences in high school and undergrad as well. And then after I completed my undergraduate degree, I didn't lock in to nursing in undergrad because they didn't have nursing as a major on my main campus. But I took prerequisites for a accelerated BSN program.
Yep.
And so after I finished my bachelor's, which was in public health, which was also my cup of tea. I'm like also
No,
like a
that's a super popular major these days. That's a great
yeah,
major.
I'm like a public health junkie nerd. Like I love
I
public
love
health.
it.
I just took the prerequisites for nursing and then I went into nursing right after undergrad. So that was nursing, and that's why
Can I ask you real quick, of any of the nurses that you saw, were any of them women of color? Was that part of the discernment process? I'm just
yeah,
curious if that was a
they
good
were
example.
because they were all within my community. So people that I knew in church or people that,
Okay.
were friends with my mom and my dad. So they were. And for that aspect, color has nothing to do with that. Because as I've gone into nursing, I've met nurses of all different cultures and backgrounds. And the one thing that we all do have in common is that we all love nursing.
Yeah.
Um,
I know the
so
reason that I asked is I think I was visiting with a doctor the other day and I said, I love that young girls can see themselves in you. And so I was just
yes,
curious if that was the case.
yes,
I love it. I love that you love nursing.
yes.
It's clearly evident, but I love that that's what led you there. All right. So tell us how you got from regular mother baby nursing. I don't want to say regular mother baby nursing
Not
to
regular.
Nick to nothing's regular nursing.
Mother baby nurses work really hard.
Yes, they do.
So that is a long story, and I'll cut it short. But I initially wanted to do labor and delivery out of nursing school. And my first job out of nursing school, it was for labor and delivery position. But what they did with all their new graduate nurses with this, that they started you in mother baby first,
Okay.
and then they cross trained you into labor and delivery. And so I ended up being at a hospital that just wasn't for me. So I ended up leaving that hospital, but I did about a year there in mother baby. And my next job was in the NICU. I had moved across the country for that first job into over to Los Angeles. Yeah. So when things didn't work out, I was like two teardrops away from moving back home with my parents to New York.
Oh,
And so this NICU job popped up, and I was just like, well, I got to take it because I have to make money. Like, I don't really I had never given the NICU a thought. I thought it was big and scary. I was like, "No, it's gonna
mhm.
be sad. Babies are gonna be, like, dying all the time. No, I don't think it's for me, but I need a job." So I went for it, and I ended up loving it. I haven't done anything different since. I've only worked in the NICU. I've floated to mother baby here and there. I've floated to some pediatric floors here and there. But NICU is my bread and butter. It is my heart. I ended up falling in love with it. And my transition from mother baby to NICU was beautiful in a sense that
Yeah,
I got the opportunity to learn what a healthy newborn looks like and a full term newborn looks
right.
like.
Mhm.
And so that just strengthened my transition because I knew what to look for and I knew what was normal. And so when abnormal or premature things came into play, I was able to just kind of decipher things a little bit faster and pick up on things. So that's kind of my journey into the NICU. It
Oh, I love
was
that.
fate almost.
Well, thank you for drinking the NICU Kool-Aid. I love that you have a bigger breadth and depth, like you've seen babies in different places in the hospital.
Mhm.
That you've seen babies in different places in the hospital and that you ended up gravitating towards NICU babies. I'm a fan. I mean, I wouldn't say that I wanted to be in the NICU either, but when we got there, I fell in love with all the people that worked there and we still keep in touch with them. I think most NICU families will tell you the same thing that they adore their NICU nurses. So you mentioned before we started recording that you're sort of in between places. You actually do travel nursing. So that's a whole other aspect. So give us an idea of what that looks
Oh
like.
gosh, so I'm in between like career shift wise.
Oh,
So
look at you. Yeah, you're doing big stuff.
yeah, no, there's so much going on. So when I said I was in between jobs, I mean I'm actually leaving travel nursing.
Look at you. Okay. Take it. Do we need to have a moment?
I need to grieve a little bit.
Okay. Okay.
I'm hanging up my travel nurse hat because my last travel nurse contract ended in January, and I just
Okay.
locked in. I've been in school for my master's in nursing education since 2021. And the end was so near in January, I was just like, I need to just not pick up another contract, lock in on schoolwork, knock it out, and graduate because I was so tired of paying tuition. um, but that is exactly what I did. So since January until basically the end of July, I had been finishing up school, finishing up my master's, and I have graduated. I do have a new job, so I will be starting a new role as a nurse educator at a hospital in New York City. And I will still kind of be in the NICU. I will be the nurse educator for labor and delivery, NICU, and mother baby. So
Wow.
yeah, I'll be
I love
covering
that.
those 3 units.
Okay, so tell us what you're going to be doing. Nurse educator. Are you going to be working solely with those three groups? Like, give us an idea of what nurse educator looks like.
Yeah, so a nurse educator you can do a number of different things, but there's two main routes that you can take. You can go into academia, so you can work at a nursing school and you can teach and you can be a professor, you could be a clinical instructor, or you can still kind of stay a little bit clinical on the clinical side and the hospital side, where you're essentially the nurse that teaches the nurses at the hospitals. So I will be in charge of making sure that all the nurses that work on those 3 units are competent in the way that they should be. If there's any new procedures that are coming out or skills or equipment that needs to be taught, I'm responsible for teaching those skills and signing everybody off and making sure that they've received that education. New hires that are new to the unit, I'm responsible for all of their onboarding and the education that goes with that. And then just some other hospital-wide stuff that I'll probably also have to partake in, but that's essentially what a nurse educator does. We're the nurses that educate the nurses.
Important job. Yes, I'm
Yeah.
glad you're there. So you also, in addition to school and that, you also founded I Know Newborn. So I want to hear a little bit about what that is and what led you to start it.
Yes. Okay. So I know newborns is my baby. That's my business that I created, and it came about because the Black maternal health crisis has been getting a lot of press, as it
Yes.
should. And when we were getting a lot of press about that and a lot of research was coming out and a lot of people were speaking up about it, and was getting a lot of momentum, and it still is. I was like, there's a lot of talk about Black moms in the United States and the Black maternal morbidity rates and mortality rates,
Yep.
but nobody's talking about the babies, and the infant mortality rates are just as jarring. When you go on the CDC website, it's double our white counterparts, Black and brown babies. It's just
Oh,
as just like I don't know, what's another word for jarring?
just as unacceptable as it should.
Just
Like
as
it's yeah,
unacceptable, right?
yeah,
There's just as much of a disparity.
right.
And we have, as adults, we're able to speak up for Black moms, and Black moms can speak up for themselves, but babies, they can't speak. Nobody can speak for them.
Yeah.
And so that's kind of how it came about. And obviously, I love babies because I work in the NICU. So I'm like, well, while we're talking about Black moms, let's also talk about the Black babies that come from Black moms and why they're dying at these crazy rates, and it's double our counterparts. Why is that? And so that's how I Know Newborns came about. I really wanted to be a hub and a resource for Black and brown parents seeking out support in the NICU. And even if they're not in the NICU, just general newborn support, and education, of be a reliable source, and just to be a person to where they can seek out information from somebody that looks like them.
Yeah. Well, I mean, I think there's this you're one of many guests that we've had that have spoken specifically to this disparity in care and like this disparity in knowledge of like how do hospitals and how do NICUs bridge that gap between those who have resources and those who don't. And so, Chelsea, as you think about like particularly your work in the NICU, I mean, how can hospitals make that gap smaller when they're educating and working with families of color, but also, like you said, with babies of color? Like, how do we shorten that gap?
Yes, that's a great question. And I think everybody's initial response to that question is going to be something along the lines of pushing implicit bias training and cultural competency training and racism and healthcare training. And we need to be, doing all of these different classes and courses and that's everybody's initial response. And those things are great and necessary, but in my opinion, we've been doing them for some time now and we still haven't seen much change. So it's got to be something more.
Right.
And so I think that's a great place to start. I think where we could take it a step further is by making sure that the people that are taking care of our tiniest babies and humans know the stark reality of the data that's out there. I can guarantee you the next time you step foot in a NICU, if you were to ask any NICU nurse on that floor what the Black infant mortality rates are currently in the United States, they wouldn't be able to answer. Or what even if the white and Hispanic and Asian, if any Black infant mortality rates, they probably wouldn't be able to answer. If you were to ask them what their infant mortality rates are on their unit, on their floor, and how that differs by race, they probably wouldn't be able to answer. And so I think that sometimes the data, like this is the public health nerd in me
I
coming
love
out.
this. No, this is great.
I think the data sometimes kind of gets pushed to the side because as nurses and working in healthcare, we get so caught up on what we have to do for the day, the tasks we have to do, but we lose sight of the bigger picture. And so I do think that there is a need for just re-educating our nurses and our doctors what the data is reflecting and what our care is reflecting, and that's our infant mortality and morbidity rates. I think people knowing, what they are, hopefully will give them a different perspective when they are caring for these tiny humans, and hopefully do so with a little bit more empathy and less bias. Because it's one thing to sit through a class that everybody's probably falling asleep, like,
Right. Yeah.
but to make it a little bit more applicable, I think it's helpful for us to really start learning what the actual data is. So I think that's one way. I can go on and on and on, but I don't want to
No,
like.
but what I love about that is if you know what the overall rates are, and then I loved what you said about, but what are they on your unit? And then if you say, hey, actually our numbers are better, then you start to say, what are we doing right? And if the numbers are worse, you can say, where are we missing? Well, what's missing here? So I think I'm also a little bit of a nerd when it comes to statistics. That was my old life when I was doing my master's degree, and I fell in love with statistics because it started making me a better, I think, educator of when I was looking at stats, like what does that really mean and what causes that and how do we implement change? So I think that you're doing the right things. And it sounds like this little role that you're about to have in nursing education is going
Yeah.
to be right up your alley. So I love that. So, what are some things that hospitals can do, Chelsea, do you think, to provide good support to the families when it comes to like discharge? Okay, so baby's been
Ooh.
discharged. I know that's a big question, but maybe give me like your top 3 things that you think would make that transition from leaving this environment where they have all the things that they need and then bam, they're out in the world and they gotta go it alone, or at least without all the people at the at a quick phone call next to them.
Yeah. So it's tough because depending on the baby, you may be expecting to stay in the NICU for weeks and weeks and weeks, or you could be there for a few days, or you could be there for a few months, right? And so there are times where sometimes discharge pops up as a little bit of a surprise. And unfortunately, sometimes there are times where parents are unprepared. Like, last week I was working at the hospital on the mother baby unit. The mom delivered and had no car seat, was pregnant for 9 months, full term, no car seat, had to order it on Amazon before going home, right? So sometimes things happen that surprises. Sometimes people are just underprepared. I think personally, and this is part of one of the good things about travel nursing is that I get to see how different hospitals do different
Oh,
things.
right.
Of the hospitals that I've worked at that have like discharge coordinators, like nursing discharge coordinators in place,
Mhm.
like specifically for planning discharge and getting those parents, especially the complex NICU discharges, where, the baby's going home on multiple meds, maybe going home with some equipment, oxygen, G tube, what have you. Those are the ones where we're so forthcoming with education, but sometimes even the simple discharges fall through the cracks.
Mm.
And you call a parent and you're like, hey, your baby's going home tomorrow. And the mom's like, what?
What?
Tomorrow? What do you mean? Like, what do you
Right.
mean? What do we mean? So there sometimes does things discharge does get lost in the sauce. And from what I've seen that works well is by having designated teams or nurses dedicated to handling the discharge, not just social workers, but actual nurses that are hired to do that, and spend time out of their shift to make sure that they've taken their CPR classes, they have the car seat is ordered and the base is installed, that they have the bassinet or their crib at home. If the baby's going home on special formula, that the WIC forms are filled out already, that they've picked up the vitamin D and polyvisol from CVS and they've learned how to give the meds. And if all of those things have not been done, then there's a plan in place for that to happen before the actual day of discharge. I actually think though that is what works best, but not every hospital has that luxury of a discharge nurse or a
Mhm.
discharge coordinator or team.
Can I give you another job, Chelsea? I think you should write a book on your best practices of things that you've
Ah!
seen around the country of these are things that you can implement, or these are things that I've seen that have worked really well, and these are the things that you should not do. So I'm going to give you another job. I hope that's okay.
Okay, got it. Adding to the to-do list.
Put it on the list. Today's podcast episode is sponsored by Neotech Products, makers of Little Sucker and Neo Sucker curved suction tips. RSV season means lots of suction. Neotech's line of suction tips are soft and flexible, which is ideal for frequent suctioning. They offer a variety of options, including anatomically curved and nasal tips to guard against tissue trauma. And all Neotech suckers feature a thumb port to control intermittent suctioning. Protective covers are also available. The latest covers feature a hook for convenient hanging. So you can visit neotechlittlesucker.com to request your free samples. Well, I know for some moms listening and some dads listening to this, when this airs, it's going to be smack dab in the middle of RSV season.
Mm,
So sometimes a baby is diagnosed with RSV when they're in the hospital. Like in our case, let me think about that. The first time we had RSV, we were actually in the hospital. The
mm.
second time, we were not in the hospital. So maybe give people an idea of like what is RSV, and then we'll talk a little bit about like what are some of the signs and symptoms that it might be more than just a cold.
Yeah. So RSV it stands for respiratory, I might even pronounce it wrong, syncopal
It's all right.
syncopal virus,
This is why we have acronyms. RSV, yes.
RSV. It's been around for a while, and it is one of those viruses that if it infects a baby, it can go really left really fast.
Right.
To you and I, it would be your standard cold in the fall and, 3 or 4 days, maybe a little bit of prednisone from the doctor, and we're back to 100%. For babies, not so much. And so, with RSV season approaching and being upon us, the number one thing to prevent RSV, especially with babies, well, with everybody, is hand washing. That's number one. So please wash your hands. Encourage people to wash their hands before they touch your baby. Wear a mask if you see somebody is sneezing or sniffling, or just abstain from holding and touching a baby. I love to hold my friends and family's babies, but I know if I've been sick, I will legit love them from afar and I will let somebody else
Yes.
get the cuddles in. And,
Yes.
next time it's all me. Next time they're all mine. But, RSV can hospitalize babies, and I've seen it because, like I said, I have floated to pediatric floors. And, once you're discharged from the hospital, once you're discharged from the NICU, if you have to be readmitted, you are admitted to a pediatric floor or a pediatric ICU. There's no more NICU after you leave.
You really graduate from the NICU. You just
Yeah,
that's the way
they
it
give you
is.
the
Yeah.
boot and you don't come back.
Yeah.
Very rarely
Yeah.
do they, admit from the outside. There's one hospital that I've seen do it a few times, but it was one of the smaller hospitals. It's actually one of the hospitals that I work at, but that I'm actually leaving for my new job. But very rarely do they readmit to the NICU. So with that being said, signs and symptoms similar to what we feel, the babies will feel. So that runny, stuffy nose, that coughing. Coughing is never normal in a newborn. So if your baby is coughing,
That's
please
good.
call your doctor. Coughing, fatigue, telltale symptom of whenever a baby is sick is just loss of appetite. That's for anything, not just
Yeah.
RSV. If they're not eating as much,
And sometimes they're not eating because they can't breathe.
they
The
can't
nasal
breathe.
canals, yeah,
Yes,
they can't breathe, so they don't wanna eat because they feel like they're suffocating. Yeah.
yes, yes, yes. Irritability, fevers. On a more moderate to severe scale, you would see like retractions. And what retractions are is a sign of respiratory distress. And so if you're watching your baby breathe and they're at rest and they're sucking in their little muscles
Yeah.
between their ribs, those are called retractions. If you see their little nasal, their nose flaring when they're at rest, that's called nasal flaring. That's them showing you a sign that they might be struggling to breathe a little bit. Or if they're grunting, which is a noise that I always like to demonstrate it because it's hard to describe what it is. But if when they're breathing, if they're making this noise, uh, 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 that is grunting and that is not normal. And then obviously, if your baby ever turns blue or stops breathing, you're calling 911.
Right.
I think that the $1,000,000 question is, well, how do I know when to take my
Yeah.
baby to the doctor? Or how do I know when to take
How did you know that that was gonna be my next question?
How do I because my friends and family ask me all the time.
Oh, yeah, we'll just ask Chelsea. She knows everything. Yes.
Literally, I'm that friend where everybody
Yes.
I'm getting random pictures of diaper rashes in my phone and all the other things,
I
but
love it.
so, I always like to tell moms, especially upon discharge, you have the motherly instinct, especially first-time mommy. You have the motherly instinct. If something doesn't feel right, take your baby to the doctor. There's gonna be no harm in that. A lot these days, a lot of doctors have they're accessible via phone and telehealth. So if you feel like the baby is okay enough, you can always utilize that resource. But when in doubt, just take them to be seen. Nobody's ever gonna fault you for being
Right.
worried about your baby. You know what I
Yeah.
mean?
Yeah.
So, but if you're looking, if and I understand that there's parents that are a little bit more like, I need you to tell me exactly when. If your baby spikes a fever, that's when you should definitely be giving your doctor a call. If they're not eating, if they're not waking up to feed either, or even like just sleeping a lot, those that would be when I would, either take them to urgent care. I would take them to the hospital if they have an episode, if they stop breathing, they turn blue. If they're doing that, retractions, those nasal flaring, any signs of respiratory distress coupled with a fever. If there's multiple symptoms that you just feel like you can't manage at home anymore, you should be taking them to the hospital. And when in doubt, just take them to the doctor. And if the doctor looks at your baby and says, take your baby to the hospital right now, then you do that.
Yes. No, I mean, I think anytime it's respiratory to the hospital, obviously, but I think you're right. I think that our instincts as caregivers and as parents, you know when something's not right with your baby, so don't and I think like you said, sometimes it can turn pretty quick, pretty bad. So don't wait, give your doctor a call or if you need to go to urgent care, but I think don't discount the instinct because we're usually not wrong.
Yeah.
We're usually right.
Yeah.
Thank you for that, because I think that sometimes parents need the encouragement to say especially I think especially when you've been in the NICU, I think I found myself we had 6 children, and it was our 5th one that was in the NICU, and I remember feeling like, "Am I being hypersensitive?" And I remember my husband looking at me and said, "No, like, you just know him, and you know when something's not right." So, encouragement to just follow through on that.
Preemies are born with babies are born with no immune system, but
But
preemies
preemies
even more
especially.
so. Underdeveloped lungs, underdeveloped immune system, haven't had all their shots yet. They haven't even left, the hospital for more than, like a day in their life. And so they're being exposed to all these germs. And so RSV season is super, super important. If you don't have to go outside, don't go outside. Wash your hands. Don't have everybody kissing up on your baby. And yeah, be the mom that's going to advocate for your baby. And just know, and this is not to scare anybody, but that babies can die from RSV and COVID and all the other crazy viruses that are out there that are too long to name. But you can be readmitted to the hospital, and your baby might be on some type of respiratory support, nebulizer treatments, all of the things, just from a simple RSV virus that is simple to us, but not so much for babies.
I remember, I think it's, I don't think you can ever, certainly if you have a baby who was born premature, I mean, our baby was born in the fall. So we were like, bam, right in the middle of RSV season. And I remember just being especially overprotective. And I would just tell my friends, I'm that mom. And I was that mom for a long time until we got him to a better place. So don't apologize if you're that mom,
Yeah.
because your baby's health is important. And I don't think that you can be too overprotective, particularly if they have a lot of respiratory issues. Maybe you left with a pulmonologist and you got all sorts of stuff going on. I remember I had a conversation with my pediatrician and she said, if these things happen, that is to the hospital. If these things happen, that's a phone call to me. And it helped. Maybe that's a conversation that people have with their pediatrician. When do I call you? Because they know your baby best. You do too. And then when is it a call to the hospital? So
And
thank
I
you for
I
that.
think those conversations are super important, because what I'm finding is, like, like I was saying, like, my friends text me a lot about their babies. And a lot of times, I want to say, what did your doctor say? Right?
Right.
Like, do
Right.
what your doctor, because I'm not a physician. Yes, I know a lot about babies, but I think there are times where the bedside manner and those important conversations where it's like, literally, okay, this is do if this then that, if this then that, are so important to have with parents. And sometimes that gets lost in the cracks, and that just adds to the anxiety of, what do I do? What do I do? Oh my God, oh my God. But if you're feeling like your pediatrician is not clear or is not responsive, find a new pediatrician.
Yeah. I'm grateful. She's earlier in the season, but my pediatrician, I actually get to interview her. And but she was also the person that knew Chelsea, like, I know that Catherine can handle this and she can't handle this. So she knew, like, maybe
Mm,
what I'm telling you to bring her in, your baby in or bring to the hospital, like, I know your family and I know what your capabilities and like your comfort level is with dealing with certain things.
yeah,
And then I know when it's past that. And that's different for every family. So I think the encouragement to talk to your doctor isn't just like, talk to your doctor and quit texting me, but talk to your doctor, because your doctor
yeah,
really does know your family and your situation about, and they
yeah,
also know your area, what things are spiking in your area and what you should be aware of. So
absolutely.
good communication with your doctor. So you have some amazing resources on your website, and I want you to tell us about some of those resources. You've got some e-courses and ebooks. So tell people where those are on your website and what you have.
Yeah. So I created so far just two, but I am in the works of creating more ebooks. But the two ebooks that I have, actually there's three. There's three ebooks.
There you
One
go.
one is a
I
freebie.
was going to say I thought there were three. Okay.
One is a freebie. One is the freebie is a hospital bag checklist. So it's just something for you to look at before, when you're anticipating the delivery of your baby, to make sure you have everything you need and don't need in your hospital bag, because people love to overpack for the hospital. I don't know why, but, like, people love to bring diapers to the hospital as if we don't provide diapers. Like, so it's like I go over stuff like that in the hospital bag checklist of, like, you don't need to bring, diapers and wipes. You don't need to bring 5 outfits for the baby. Bring like 2. Like so I go over that in the hospital bag checklist, and I cover things for the baby and for mommy. So that was like my little mother baby nurse kind of like creeping in.
Yes, I love that.
And then the other two are more NICU specific. One of them is NICU parent glossary. So I spent time thinking of all the words that I could possibly use in a day, and acronyms and shorthand whatevers, medical terminology in the NICU, and I put it into a glossary for parents.
It's awesome.
It has about 300 terms in it, and I break it down into layman's terms, just regular everyday English, so that when people are working, not sorry, when parents are at the hospital and maybe they're sitting in on rounds for their baby, or they're talking to doctors, or they overhear nurses talking, and report, they can keep up with the shorthand and the things that they're saying about their child.
It's a foreign language. So yes.
Yeah,
It really
it
is.
is. It is. But I see it as a way to strengthen the parent's ability to advocate for their child.
Yes.
Because a lot of times I'll say we are all guilty of it. We will go into that medical terminology, shorthand talk, knowing that maybe, like, the parents don't know every single thing that you're saying, in order to ease anxiety or to not over, induce anxiety in
Mhm.
parents. But what I found is that when parents understand more, there's less anxiety.
I was just getting ready to say that. I actually think that brings more anxiety when you don't know what they're saying and it sounds more serious than if you knew what they were saying. You're like, okay, now I know how to process that. Knowledge
Yeah.
is important.
Yeah, I try to make sure I spend time, like, defining things a lot, especially not maybe not so much during rounds, but, like, in preparation for discharge, and just if there's a change in their baby, like if we're doing a rule out of sepsis, I'm defining all the things, like, here are the reasons why your baby was doing this. This is why this is here. This equipment is this, where this is new, but blah, blah, blah. So I find that that does ease a lot of anxiety if you just tell them what it is, plain and simple. So the glossary was created with that in mind. And then the other ebook is the NICU Parent Advocacy Script, where I basically drew up a script for parents to use when they're talking to physicians or nurses, either during family meetings or during rounds, when they want to speak up or when they want to advocate something for their baby. And I made a script utilizing terms that we were taught in nursing school, and I'm sure that the physicians were taught in medical school. Key words that will make a nurse and a doctor stop dead in their tracks and listen to a parent.
That sounds important. I love that.
Yeah. I put that all into a script because we were, as nurses, we're trained on how to communicate with physicians or other nurses when we're concerned about something or when something isn't right. And we're trained on how to say those things to make sure that we get the attention of the provider. And so I basically took that tool and I put it into a parent script. So that way, when you're sitting in these family meetings, you can feel confident that you're going to be heard because they're going to hear these key terms and they're going to be like, oh, snap.
Someone's paying. So people can find that at iknownewborns.com. Is that right?
Yes,
Okay.
yes, yes.
All right. So definitely go check that out. So I always love to ask this as my last question. In previous seasons, it was advice, but because this season is all about hope, I want you, what piece of hope would you give to a family that feels overwhelmed with their NICU stay?
So, two things come to mind when I'm talking to parents that are overwhelmed or maybe a little anxious. I like to tell them and coach them to celebrate all the small wins. So that means, your baby took their first bottle today. That is a small win. Maybe he didn't take all 8 bottles that he gets in a 24-hour period, but he took one full bottle. You should be celebrating that, right?
Yeah.
The NICU is very much a marathon and not a sprint. And I know that it can get weary, especially when you're getting close to discharge and you're like, when is he going home? When is she coming home? We just want to go home. We're tired of being here. We're tired of coming here. But it is very important and it will keep you a little bit sane to focus on the broader picture and but also celebrate the small wins and not to try to push your baby too much. Like your baby is the boss, essentially. And you want to make sure that he or she exits the NICU in the healthiest way possible. And so you just have to follow their lead. And when you do that, you will go home when the time is right. And so that's usually kind of what I like to tell parents. And then the other tidbit, when I think of like hope and maybe just like decreasing anxiety, I like to tell parents, if your nurse is not freaking out, you don't freak out.
Well, that's good advice.
Just everybody take a deep breath. I am not freaking out. You don't have to freak out. You will know when the nurses freak out. It will be clear. Okay. Right.
Right.
So if I'm cool about it, you be cool about it. If I'm not worried about it, don't get caught up on the little tiny things and the numbers. Let the nurses worry about the beeping and the monitors and the DSATs and the Brady's. Let us worry about that. You focus on your skin to skin with your baby, because the more you lower your anxiety, the faster you can get out of the NICU, because you can transfer your anxiety to your baby. You can transfer those emotions. And the best thing that you can do for your baby is take care of yourself first, so that you can be present and take care of your baby. So those, I don't want to ramble.
No,
Those are
that is excellent advice, and I'm going to remember that. In fact, I'm going to tell my teenagers, if mom is not freaking out, you should not be freaking out. So,
there you go.
hey, Chelsea, thank you so much for being here. Well, it was another great interview. As expected, today's 2-minute take. First, I could have asked Chelsea so many more questions, but there were a couple things that, as I was listening to her visit, I think I've heard some of those things before, but it was, how sometimes somebody says something and you hear it in a whole new way? I think this reminder that I know my baby best. So, particularly when we're talking about RSV season and maybe this concern, like, how do I know when I need to take my baby to the doctor, to the hospital? Is it something that I can just treat at home? Like, when is it serious? And I thought Chelsea's advice of ask your doctor. I mean, I know we joked about it a little bit. She's like, people are texting her, but she's like, ask your doctor. Y'all, you have a pediatrician or hopefully a trusted person in the healthcare industry that knows your baby and knows your family best. Please reach out to them. They certainly know the area that you're in and what illnesses are floating around, if it's RSV or something else. But they also know what your capabilities are as a family. Like, this family I know can treat that at home, but this family may need a little bit more assistance for various reasons, and they need to come see me in the office, or maybe they even need to go to the hospital. So have that conversation with your pediatrician before it gets serious, so that when it does get serious, you have a plan. I really, really, really love that. And speaking of things that I really loved, on Chelsea's website, she was telling us about all the different e-resources that she has, ebooks, some free, some paid. But how much am I loving the fact that she has a script of things that you can ask your nurses and your doctors that they're going to pay attention to and be like, oh, this person is serious. I love that she has that resource, so you can check that out at iknownewborns.com. You can definitely listen to more of our episodes. We've got more episodes coming this season in season 8, which is all full of hope. But please leave us a review over on Spotify or over on Apple Podcasts. You can also watch us over on YouTube. But don't go anywhere, because next week we're going to be chatting about this.
When there is stress in the family, when there's more anxiety, when something happens that kind of pulls the family apart, resources, time, and so on and so forth, children tend to turn to each other. And we think that this is how they are turning against each other. That's actually somewhat their support system. I'm not saying it's okay that they're fighting with one another,
Right.
but this is their way of actually getting or taking out some of that anxiety.